Welcome. Today we tackle interstitial lung disease, a family of more than 200 disorders that scar the lung from the inside. It intimidates residents because the list is enormous. So we will not memorize the list. We will build a framework. We will follow one patient whose scan looks like classic pulmonary fibrosis, and we will watch that first impression fall apart. Because the most important skill here is knowing when idiopathic is the wrong answer. Here is our patient. A 65-year-old woman comes in after 8 months of slowly worsening breathlessness. At first, it was only long walks. Now a single flight of stairs stops her. She has a persistent dry cough, no fevers, no chest pain. She has never smoked. This tempo matters. Not minutes, not years. A subacute decline over months is the classic way interstitial lung disease announces itself. Here is what you will take away. First, you will define interstitial lung disease and the restrictive physiology behind it. Second, you will sort any case into 4 broad categories. Third, you will read the high-resolution CT patterns that drive the diagnosis. Fourth, you will separate idiopathic pulmonary fibrosis from the conditions that imitate it. And fifth, the theme of the whole video, you will learn when to stop calling a disease idiopathic. Let us build the history. Her breathlessness came on insidiously and has marched steadily upward. The cough is dry and nagging, worse when she lies flat. She has had no fevers, no night sweats, no weight loss. That absence pushes infection and malignancy down the list. What we have is a slowly progressive process, restrictive in flavor, and now severe enough to reshape her daily life. So the workup begins. Now the focused history. And this is where the diagnosis is often won. She keeps 2 pet parrots. Bird exposure raises hypersensitivity pneumonitis. She describes her fingers turning white in the cold. That is Raynaud phenomenon. Her hands are puffy and stiff in the morning, and the skin over her fingertips is cracked and roughened. Those last clues point away from the lung and toward a connective tissue disease. Hold on to both threads, birds, and hands. On examination, she looks well at rest, but tires quickly. Listen at the bases and you hear fine, dry crackles. They sound like Velcro pulling apart. That is the signature of fibrosis. Her fingers show mild clubbing, and the roughened fingertip skin has a name. Mechanics hands, a marker of one specific connective tissue syndrome. Her oxygen saturation is 92% at rest, but it falls to 86% when she walks. Exertional desaturation is a red flag. So what are we treating? The interstitium is the delicate scaffold between the air sac and the capillary. It is where oxygen crosses into blood. Interstitial lung disease is any process that inflames or scars that scaffold. More than 200 distinct disorders live under this umbrella. They differ wildly in cause, but they share one endpoint: a thickened barrier, stiff lungs, and oxygen that can no longer cross efficiently. Understand the scaffold and the whole topic clicks. Interstitial lung disease arrives in 3 very different ways. Sometimes it is silent, found by accident on a scan ordered for something else. Most often it looks like our patient. Subacute breathlessness building over months. And occasionally it is an emergency. Rapidly progressive hypoxemic respiratory failure over days. The tempo is your first triage tool. A fast crash suggests infection, heart failure, or an acute pneumonitis. A slow climb suggests fibrosis. Let us build the mechanism. Follow the pathway. Something injures the alveolar lining cells. An inhaled antigen, a drug, an autoimmune attack, or an unknown trigger. The damaged epithelium releases signals that recruit inflammatory cells. In some diseases, the process stops at inflammation and can heal. But when the signaling turns on fibroblasts, they lay down collagen. The scaffold thickens into scar. Notice the fork. Inflammation may reverse. Established fibrosis usually does not. That fork decides the treatment. Now the framework that tames the list. Sort every case into 4 buckets. 1. Sarcoidosis, a granulomatous disease of its own. 2. Exposures, drugs, dusts, molds, and radiation. 3. Connective tissue disease, the lung as a target of autoimmunity. And 4. The idiopathic interstitial pneumonias, disease with no identified cause. Here is the discipline. Idiopathic is the last bucket for a reason. You only earn it after the first 3 are excluded. Before you chase a rare fibrosis, rule out 3 common imposters that fill the lung diffusely. Heart failure. Check an NT-proBNP and consider a trial of diuresis. Infection. Viral and atypical bacterial pneumonias can look interstitial. And malignancy, especially lymphangitic carcinomatosis, cancer spreading along the lymphatics. These 3 are common, treatable, and missed when the team jumps straight to fibrosis. Exclude them first. Every time. The history does more diagnostic work than any blood test. 2 questions drive it. How fast? And exposed to what? An acute course over days points to infection. Heart failure, hypersensitivity pneumonitis, or an acute eosinophilic pneumonia. A chronic course over months points to fibrosis and connective tissue disease. Then map the exposures. Occupation, birds and mold. Tobacco, prior radiation. And every drug. Our patient gives us both a bird exposure and autoimmune clues. Here is a habit that changes diagnoses. In any interstitial lung disease, examine the skin and the joints. Raynaud phenomenon, puffy or stiff hands. Arthritis, a rash, cracked mechanics hands, dry eyes and a dry mouth. Each is a fingerprint of connective tissue disease. The lung is often the loudest organ, but the diagnosis is written on the hands and face. Our patient has Raynaud and mechanics hands. That is not a coincidence. It is the answer forming. High-resolution CT of the chest is the center of the workup, and distribution is the first read. Look top to bottom. Upper lobe predominant disease suggests hypersensitivity pneumonitis, sarcoidosis, silica, and coal dust, and Langerhans cell disease. Lower lobe predominant disease suggests the two big fibrotic patterns, UIP and NSIP, and asbestosis. Before you name a pattern, name the zone, because zone alone already has your list. Beyond zone. 2 more CT clues carry weight. Look at the lymph nodes. Enlarged hilar nodes suggest sarcoidosis or malignancy. Calcified eggshell nodes suggest silicosis. Then look at the pleura. Calcified pleural plaques are the signature of prior asbestos exposure, and scattered thin-walled cysts point toward lymphangioliomyomatosis or Langerhans cell disease. 1 scan, read in layers. Zone, nodes, pleura, cysts. Pulmonary function testing confirms the physiology. Interstitial disease is restrictive. The lungs are stiff, so the volumes are low, but the earliest and most sensitive change is a fall in the diffusing capacity. The DLCO, because the thickened barrier blocks gas transfer before volumes drop. Expect desaturation with exercise. 1 trap, when fibrosis and emphysema coexist, called CFPE, the volumes can look deceptively normal while the DLCO collapses. Send a serologic panel to hunt an autoimmune cause, an anti-nuclear antibody, rheumatoid factor, and anti-CCP for rheumatoid disease, ANCA, when vasculitis is possible. And critically, a myositis and antisynthetase panel, because inflammatory myositis can present with lung disease first. The serum ACE level is often checked for sarcoidosis, but it is neither sensitive nor specific, so treat it as a hint, never a diagnosis. Not every patient needs a biopsy. Bronchoalveolar lavage, a saline wash of the air sacs, helps when you suspect infection. Alveolar hemorrhage, or an eosinophilic syndrome, a lymphocyte count above 35% points toward hypersensitivity pneumonitis or sarcoidosis. Tissue biopsy, by cryobiopsy or surgical VATS, is reserved for when the cause stays unclear and the answer would change treatment. Sample with a purpose, not by reflex. Here is the modern standard. The diagnosis of interstitial lung disease is not one test. It is a conversation, a multidisciplinary discussion. Pulmonology, radiology, and pathology sit together. They integrate the high-resolution CT pattern, the serologies, the exposure history, and any biopsy. Studies show this discussion changes the final diagnosis in a large share of cases, so the best diagnostic tool is often the meeting itself. Now back to our patient. Her high-resolution CT shows slower lobe, subpleural reticular scarring, traction bronchiectasis, and early honeycombing. This constellation has a name, a usual interstitial pneumonia pattern, UIP, and UIP is the fingerprint of idiopathic pulmonary fibrosis. The team is ready to call it IPF and start antifibrotic therapy. Pause here and ask, have we actually earned the word idiopathic? Here is the twist. Remember her hands. Raynaud phenomenon and mechanics hands were never incidental. Her myositis panel returns a positive antisynthetase antibody. This is connective tissue disease, interstitial lung disease. Antisynthetase syndrome. The UIP pattern was real, but the cause was autoimmune, not idiopathic, and that flips management. Idiopathic fibrosis is treated with antifibrotics. Autoimmune fibrosis is treated with immunosuppression. The label chose the drug. Now, the high-yield entities. Start with sarcoidosis, its own category, and a great mimic. It typically strikes in the 3rd through 5th decades, with higher rates in African American, Northern European, and female patients. The hallmark lesion is a non-caseating granuloma, a tidy ball of immune cells with no central necrosis. It can appear in almost any organ, but the lungs and the chest lymph nodes are involved most often. Sarcoidosis rewards a head-to-toe look. The skin can show waxy plaques, violaceous lupus pernio on the face, or tender red erythema nodosum on the shins. The eyes can develop uveitis, the heart can develop conduction block, arrhythmia, or cardiomyopathy, and the calcium can climb, because sarcoid macrophages activate vitamin D. Two manifestations are dangerous and easy to miss: cardiac sarcoid and neurosarcoid. Screen for them. Sarcoidosis on the chest film is staged 1 through 4. Follow the ladder. Stage 1 is bilateral hilar adenopathy alone, big nodes, clear lungs. Stage 2 adds interstitial disease to the nodes. Stage 3 is interstitial disease, with the nodes now resolved. And Stage 4 is diffuse fibrosis. One special pattern deserves its name: Lofgren syndrome. Erythema nodosum plus hilar adenopathy plus arthritis. It carries an excellent prognosis and often needs no treatment. Confirm sarcoidosis with tissues showing non-caseating granulomas. Endobronchial ultrasound-guided sampling of a chest node is the modern first choice. Always exclude infection and lymphoma, which can look identical. Treatment is selective. Not everyone needs it. Reserve corticosteroids for symptomatic disease or dangerous organ involvement. Heart, eyes, brain, or kidneys, because roughly 2/3 of patients remit on their own. Steroids ease symptoms, but do not clearly change the long-term course. Now the idiopathic interstitial pneumonias. A family, not a single disease. Each member is defined by a blend of imaging pattern, histology, and clinical course. They include idiopathic pulmonary fibrosis, nonspecific interstitial pneumonia, organizing pneumonia, and a few others. The word idiopathic is doing real work here. It means you have genuinely excluded drugs, exposures, and connective tissue disease. Exactly the step our patient nearly skipped. Idiopathic pulmonary fibrosis is the one you cannot miss. Its imaging signature is the usual interstitial pneumonia pattern. UIP, reticular scarring, honeycomb clusters of cystic spaces, and traction bronchiectasis, all concentrated at the periphery, just under the pleura, and at the lung bases. The story is a slow cough and dyspnea over more than a year, usually in an older patient. Untreated, the prognosis is worse than many cancers. Idiopathic pulmonary fibrosis is treated with antifibrotic drugs, pirfenidone, and nintedanib. These do not reverse scar, and they are not immunosuppressants. What they do is slow the decline in lung function over time, measured as the forced vital capacity. Around them sits the supportive core. Supplemental oxygen, pulmonary rehabilitation, and early referral for lung transplant in fit patients. Steroids alone do not help idiopathic fibrosis and can harm nonspecific interstitial pneumonia. NSIP is the pattern that should make you think autoimmune. Instead of coarse honeycombing, you see smoother ground glass and fine reticulation. The giveaway is subpleural sparing, a thin ribbon of normal lung hugging the chest wall. It is symmetric and basal, and it travels with connective tissue disease. So when you see an NSIP pattern, send the autoimmune workup before you say idiopathic. Put the two fibrotic patterns side by side. On the left, UIP, honeycombing, coarse, and heterogeneous. No subpleural sparing. Classically idiopathic pulmonary fibrosis. Worse prognosis. On the right, NSIP, ground glass, uniform and smooth, subpleural sparing present. Often connective tissue disease, better prognosis. The visual difference is honeycomb versus ground glass. The clinical difference is antifibrotic versus immunosuppression. That contrast is the heart of this video. Two more idiopathic pneumonias earn recognition. Cryptogenic organizing pneumonia, COP, shows patchy consolidations that seem to migrate between scans. It mimics infection, but antibiotics fail, and steroids work beautifully. The prognosis is excellent. Its opposite is acute interstitial pneumonia, AIP, a fulminant process that looks and behaves like the acute respiratory distress syndrome. It develops over days and carries a high mortality. Tempo separates them. Some interstitial disease is simply the cigarette. Two smoking-related patterns: desquamative interstitial pneumonia and respiratory bronchiolitis interstitial lung disease. Both cluster in current smokers. Both fill the alveoli with pigmented macrophages. Here is the hopeful part. For these two, stopping smoking can be curative on its own. Steroids are sometimes added, but the cornerstone is a prescription no pharmacy fills. Quit. Return to our patient's parrots. Hypersensitivity pneumonitis is an immune reaction to an inhaled organic antigen. Bird proteins in bird fancier's lung, thermophilic microbes in farmer's lung, and molds in humidifier lung. It favors the upper zones and shows loose non-caseating granulomas. The single most powerful treatment is not a drug. It is finding and removing the antigen, which is exactly why we asked about the birds, even when the final answer was autoimmune. Connective tissue disease, interstitial lung disease deserves its own moment because it is our patient. Scleroderma, inflammatory myositis, rheumatoid arthritis, and Sjogren disease all attack the lung. In several of them, lung involvement is the leading cause of death. The usual imaging pattern is NSIP, though UIP occurs, as it did here. Treatment is immunosuppression. Mycophenolate and rituximab are common choices. This is the fork antifibrotics would have missed. The pneumoconioses are interstitial diseases of inhaled inorganic dust. Coal and silica scar the upper zones. Silica also raises the risk of tuberculosis and can calcify lymph nodes into an eggshell rim. Asbestos is different. It scars the lower zones and leaves calcified pleural plaques, and it raises the risk of mesothelioma and lung cancer. Beryllium is the great imitator, a granulomatous disease essentially indistinguishable from sarcoidosis without an exposure history. Always scan the medication list. Drugs cause interstitial lung disease. Amiodarone is the classic offender. It can produce a pneumonitis that shades all the way into a picture like the respiratory distress syndrome. Nitrofurantoin and hydralazine are common culprits. And among chemotherapies, bleomycin, busulfan, and methotrexate are notorious. The treatment principle is simple. Stop the offending drug and add corticosteroids when the reaction is severe. One more bucket. Pulmonary infiltrates with eosinophilia. Here the lavage or the blood is rich in eosinophils. Causes include allergic bronchopulmonary aspergillosis and eosinophilic granulomatosis with polyangiitis. Acute eosinophilic pneumonia is a fulminant febrile illness. Chronic eosinophilic pneumonia has a memorable sign: peripheral infiltrates that look like the photographic negative of heart failure. Most of these melt away with corticosteroids. 3 uncommon entities are worth naming because they are distinctive. Pulmonary alveolar proteinosis. The air sacs fill with surfactant-like material, and the lavage returns a milky fluid. Lymphangioliomyomatosis, cystic lung disease in women, treated with sirolimus. And Langerhans cell histiocytosis, seen in young smokers, with upper zone cysts and a risk of pneumothorax. You will not diagnose these daily, but their pictures are unmistakable. Whatever the specific diagnosis, a supportive core applies to everyone. Supplemental oxygen for hypoxemia, pulmonary rehabilitation to preserve function and quality of life. Treat reflux, which can drive some fibrosis. Screen for pulmonary hypertension, a common and treatable complication. Vaccinate against respiratory infection, and refer fit patients for lung transplant early, before they are too sick to qualify. The disease may be rare, but this checklist is universal. Let us collect the traps. First, calling a UIP pattern idiopathic before excluding connective tissue disease and exposures. Our patients near miss. Second, never reading the medication list and missing amiodarone. Third, checking oxygen only at rest and missing the desaturation that appears on walking. Fourth, forgetting that sarcoidosis can hide in the heart. Fifth, treating migratory organizing pneumonia as a bacterial infection and cycling antibiotics that never work. Let us close our patient's loop. Assessment. A 65-year-old woman with connective tissue disease, interstitial lung disease, antisynthetase syndrome, carrying a UIP pattern that first masqueraded as idiopathic fibrosis. Plan: immunosuppression with mycophenolate, not antifibrotics alone. Remove the birds. Add oxygen and pulmonary rehabilitation. Screen for pulmonary hypertension. And co-manage with rheumatology. One careful history changed her entire treatment. Carry 5 things out of this video. 1. Interstitial lung disease is more than 200 diseases sharing one scarred scaffold. 2. Sort every case into 4 buckets: sarcoid, exposure, connective tissue disease, and idiopathic. 3. The high-resolution CT zone and pattern drive the diagnosis. 4. Honeycomb UIP versus ground glass NSIP is the fork that chooses the drug. And 5. Never say idiopathic until you have excluded the causes you can name. These are the primary sources behind this lesson: the American and European Respiratory Society guidelines on pulmonary fibrosis, their classification of the idiopathic interstitial pneumonias, the hypersensitivity pneumonitis guideline, the major sarcoidosis statements, and the landmark antifibrotic trials. Use them for the underlying evidence and the grading behind each recommendation. Thanks for working through this case with me.